colleague. Greetings from Vadodara, Gujarat, and I am Dr. Amit Shah. At the outset, I would like to thank organizers Dr. Bhiku Kalyani Das Madam, Dr. Indrani, and entire team for giving me this opportunity to speak in this meeting. And I'll be speaking about how I do it, video laryngoscopy. So I would like to disclose that we have developed a video laryngoscope device and we have a commercial interest in this particular device. But what I have expressed, what I am trying to explain here is the evidences and the views, and it is not to compare any device with our own device. So video laryngoscopy is essentially, instead of direct view from outside, it is your view beyond the curvature of tongue, so that the primary curve, you overcome primary curve, look straight away towards larynx, so you don't need to align axis, you don't need to maintain proper position, force is not necessary, and there is a large field of view. The device which looks around corner of tongue is called indirect laryngoscope, and if you use video camera, it is called the video laryngoscope. So video laryngoscope by definition is a device which is used in place of line of sight visualization to accomplish endotracheal intubation. Now, earlier with direct laryngoscopy, there are very few devices and we had to do very few things before we start the anesthesia. But now there are multiple devices and we have to understand. So we'll try to understand how to differentiate and classify them and how to optimize intubation with each type of device. If you really carefully look at the blade part which goes inside oral cavity of every device, it has a different shape and angle, and we need to understand that. So first to develop was a device which can be which was essentially anatomically shaped as per the oral cavity, but the device tip was almost pointing towards vallecula, and we can call it hyperangulated device. Second to develop was later on to facilitate easy intubation, a device which was still again anatomically curved but not as much angulated, and it was sort of pointing towards vocal cord rather than vallecula, and we can they were channeled video laryngoscopy blades and they are anatomically curved, and of course camera could always be incorporated in Macintosh type of a laryngoscopic blade and can be used as a video laryngoscope. So video laryngoscope can be classified as anatomically shaped and non-anatomically shaped. Anatomically shaped can be hyperangulated or angulated channel video laryngoscope, and non-anatomically curved could be Macintosh type of video laryngoscope. So to understand device and optimize intubation with the video laryngoscope, you have to understand angle of blade, which you have already understood. You also have to understand direction of camera and in which direction the vision is, and what is the area of the vision which is available. Also, to successfully intubate, you need to, as in the video laryngoscope, you are looking somewhere else and intubating somewhere else, you need to develop hand-eye coordination. So we'll try to understand how to optimize intubation with the various types of device. So first we'll look at the hyperangulated non-channel type of a device. Hyperangulated non-channel type of device looks up towards larynx. Epiglottis do not block your view and force requirement is actually minimum. But since the angle is hyperangulated, the endotracheal tubes are not shaped like that. You need to change to reach larynx. You need to change the shape of the endotracheal tube with the help of a stellate. Majority of the device are supplied with their dedicated stellate according to angle of their blade. But if you don't have one, then you can use regular stellate, which you can change the shape of endotracheal tube according to your blade. Once this hyperangulated stellate with the stellated endotracheal tube, once you reach the larynx, if you push it further, it will go and hit anterior tracheal wall and you might feel impingement or you may create trauma. So to avoid that, what you need to do is to withdraw stellate outside the larynx and only push endotracheal tube without stellate into the larynx, and this is very, very essential. So here, if you look at carefully, I have introduced, this is CMAC D blade. You get a fantastic view, and once you introduce this hyperangulated stellated endotracheal tube from the corner of mouth, once you reach the larynx, you carefully observe my fingers. I am only pushing endotracheal tube without stellate. It is essential that you push only endotracheal tube. So these are the 4 important points which you must understand to intubate with a anatomically shaped hyperangulated non-channel blade. Now, anatomically shaped channel video laryngoscopes are, as already discussed, it looks straight and the tip is not pointing towards valvular, it is pointing towards laryngeal opening. So epiglottis may come in your view and you need some lifting force to elevate the epiglottis. After achieving proper view, once you push the endotracheal tube through dedicated channel, it will go straight towards larynx, and passage beyond larynx does not require any further manipulation. But because of this dedicated slot, because this tube track and view axis are connected, if your tube is not going towards laryngeal opening, for altering direction of tube delivery, you require manipulation of device or endotracheal tube. Here, if you look at carefully, as the tube comes out from the channel, it goes slightly down, and then the natural curvature of tube, endotracheal tube shape, it takes up towards the laryngeal opening. So you need to withdraw the device to allow PVC tube curvature to take its own course, or you may need to pull up to help to direct tube anteriorly. Also, you can do side-to-side movement of the device so that tube trajectory can be altered towards laryngeal opening. Or you can manipulate the endotracheal tube as you are pushing it in the channel, so that tube can be sway sideways on either side by doing clockwise or anti-clockwise movement, so that the tube can be directed towards laryngeal opening. Macintosh type of a video laryngoscope blade, basically you may or may not require stellate introduction. You can be introduced from the center of oral cavity or from the angle of mouth. Procedure, pressure and displacements are almost similar to conventional, so it is good for the teaching, but its role in difficult airway has been questioned by few authors. So this is Macintosh type of a video laryngoscope blade. If you carefully look at this patient, you get a good view, but you can intubate without use of stellate. So I'm introducing it without use of stellate. You can directly intubate. There are many Macintosh type of devices are available in the market, and in fact even you can use bougie with the such video laryngoscope devices. So golden rule for successful video laryngoscopy: you need to check the device, battery, charging, anti-fogging, etc. Angle and channel blade video laryngoscopes devices are introduced from the center of oral cavity. Sniffing position may not be helpful according to one study where they have compared, they have seen sniffing position as a counterproductive position in angulated and hyperangulated, so the anatomically shaped device. Always look inside oral cavity whenever you are introducing any either device or endotracheal tube, and you should not see only on the screen, which creates blind spot. Experience with standard Macintosh blade laryngoscope does not equate to the skill with the video laryngoscope. Experience with one video laryngoscope does not mean that you have skill for every video laryngoscope. A good video laryngoscope you may not guarantee you easy intubation. A bougie may not be of solution, especially in anatomically shaped device. And the video laryngoscope chosen must be selected according to the indications and according to these 3 clinical situations: rescue or anticipated difficult airway, hyperangulated or anatomically shaped channel video laryngoscopes will work better. For routine users, that Macintosh type of device really works well and easily. But after little experience, you can easily use anatomically shaped device. But if there is a blood in the airway, only device which works is a Macintosh type of device. Now we'll try to look at the update on various situations and procedures where video laryngoscopy can be done. So first we'll look at the Cochrane review, which was published in 2016. 64 studies identified during this 2015 survey that enrolled 7,000 patients. And authors very clearly identified that video laryngoscopy may reduce number of failed intubation, particularly among patients presented with a difficult airway. They may improve glottic view and may reduce the laryngeal or airway trauma, but it may not reduce number of intubation attempt or incidence of hypoxia or respiratory depression. So adult patients, VL versus DL, adult patients, if there is a difficulty, it is going to have a definite role. Again, video laryngoscopy versus direct laryngoscopy, known difficulty for the experienced anesthesiologist. 9th study, including 1,329 patients, use of video laryngoscopy was associated with significant better view, less mucosal trauma, and it has definitely added value for experienced anesthetists, improving first pass success and the view of glottis and reducing mucosal trauma. In children, results are not so encouraging. Evidence suggests that indirect laryngoscopy or video laryngoscopy leads to prolonged intubation time with the increased rate of intubation failure when it compares with the direct laryngoscopy, though this is very low quality evidence. So it might lead to improved view, but we are not sure about its other part of the intubation success. Similarly, other meta-analysis also concluded that there is no benefit in pediatric patients on time to intubate and failure of the first attempt. They are nearly same with the direct laryngoscopy. In obstetric patients, there are 4 RCTs with 428 participants, 9 observer studies, and 35 case reports were included, where 100 participants were there. So first pass success rate and time for tracheal intubation demonstrated no difference in video laryngoscopy and direct laryngoscopy in patients without difficult airway. But patients' observation studies and case report underline the role of video laryngoscopy as a primary choice when difficulty with tracheal intubation is expected as a rescue modality or in difficult or a failed intubation. Similarly, orotracheal intubation comparison of video laryngoscopy versus direct laryngoscopy outside operation theater, where they identified 15,000 plus emergency intubation. VL compared with direct laryngoscopy associated with greater first pass emergency intubation in ICU and among less experienced clinician reduces the esophageal intubation, but it was associated with higher hemodynamic instability. Video laryngoscopy versus direct laryngoscopy, neonates author concluded that though there is a moderate to very low quality evidence suggests that video laryngoscopy increases the success of intubation in the first attempt, but does not decrease time to intubation or number of attempts for the intubation. For awake tracheal intubations, 8 studies including 429 patients were included. Video laryngoscopy for awake tracheal intubation is associated with shorter intubation time. It seems to have success rate and safety profile comparable to fiber optic bronchoscopy. In obese patients, 1023 reports initially identified 8 RCTs involving 747 patients were eligible. A video laryngoscopy overall superior for tracheal intubation as it improves glottic view and makes intubation easier in short intubation time and reduce intubation failure in obese patient. Again, it has identified another meta-analysis in obese adult identified that performance of both type of video laryngoscope, with or without tracheal tube guide, was superior to that of Macintosh laryngoscope, except for the intubation time where channel video laryngoscope works better. So at end of my lecture, video laryngoscopy definitely improves glottic view in all the situations. It improves success rate in predicted difficult or difficult airway situations It has been found helpful in emergency room, obese individual, obstetric patients, and neonatal patients. In pediatric patients, though it provides better glottic view, it may take prolonged time and authors' conclusions are not encouraging. And in awake tracheal intubation, it is as good as fiber optic intubation. Thank you for your kind attention.